Okay. Yeah, and for those of you just now hopping on, welcome. Like I said, my name is Stephanie. Feel free to turn on your cameras if you want as we go through this. Y'all can unmute and chat, or you could just, type in the chat, whatever you're most comfortable with. So without further ado, oh, this is kind of funny. I have chronic headaches, and it's probably from at least one of those things. Probably dehydration, honestly, because I like to run, and I feel like in the summer I do a run and then I come home and like drink a glass of water, but like it's never enough to make up for all the sweat that I lose. So anyway, okay. So this session is going to be a little bit different. You guys, does everybody have access to the soap note and like the quiz and everything, this type of thing? If you don't, let me know. But or like at the end too, I can just give you access to the quiz. Perfect. So if you don't, I mean, I can give it to you, but otherwise, this is going to be a little bit different. You guys can fill it out if you feel like it or want to. But because this topic is brain tumors, I didn't want to do a single case. Like I wanted to give a bunch of different cases, but like they're not going to be as in depth just because I think it's like with a topic as large as brain tumors, I think it's kind of like not helpful to just focus in on one and like one patient presentation. I think in order for you guys to learn like a general overview of like the brain cancers and things like that, it's good to show different case presentations. So it might not necessarily, you might not be able to fill out like the soap note, but if you want to for like any of this, any single case, you could choose to like focus on that as we go through. And we're just going to go through like 4 mini cases to highlight like the different brain tumor pathologies, just so y'all can get a good overview of the different types of brain tumors. Okay, so let's just dive right in and start with case number 1. So I'll just go ahead and read it. So 6-year-old boy, he was brought to his primary care physician with a 1-week history of headaches, nausea, vomiting, blurry vision. He has a history of exercise-induced asthma, and he takes an inhaler for that. He also has a remote history of tonsillitis when he was 3 years old, and he had a tonsillectomy at age 4. On exam, you note that he is alert and oriented. His temperature is 37.3, his pulse is 82, and his heart rate, that should say blood pressure, is 115/78. Heart and lungs sound normal, and on motor exam, he has weakness of his lower extremities, and he walks with a broad-based gait. So basically, he walks with his feet spaced widely apart and trying to steady himself, essentially. So if you want to take notes on that, or, I can always go back to as we walk through some of this questions and start thinking about this case. Okay, but I'll move forward. So some questions to consider then. So what is the significance of the motor exam? And again, keying into the motor exam, he has weakness of his lower extremities and he has a broad-based gait. Does anybody have any ideas about why this is significant, or is this significant at all? Let's start with, is this a normal motor exam? Yeah, difficulty with balance is what Adam says. Yeah, that's great. So yeah, and are you talking, did you come to that conclusion? Yeah, cerebellum issue. Great, wonderful. I love how we're already thinking about connections to the brain. So yeah, broad-based gait, that's obviously having difficulty with coordination and with balance, right? Because usually when people are walking where they like have their feet spaced apart, it's so that they can steady themselves, right? So that kind of clues us into, oh, maybe this guy's having an issue with balance. Additionally, obviously, weakness of your lower extremities, especially for a young boy, is not, particularly normal. Okay, so great. And then what would be our next step in management? And this can just, best guess or just anything that you can think of. Any ideas? How about this? Somebody comes in, could we do an eye exam? Bridget, why are we saying eye exam? That's a great one. But what led you to suggest that? Yeah, problems with vision, exactly. So he says that he's had some like blurriness, difficulty with vision, his nausea and his vomiting, CT. So yeah, imaging, wonderful, yeah. So yeah, we would take a more extensive physical exam. So as Bridget pointed out, that would be great. Obviously, we should ask him some more questions. We should get mom's input, kind of see what the baseline is for this boy. But ultimately, it's really important that we get imaging, right? Because anytime we're worried about something where the pathology could be in the brain, we want to get imaging right away. And again, what pointed us to this was the weakness, the broad-based gait, some of the other symptoms he's having. Maybe check cranial nerves for overall functioning and probably go for a head CT to start. Yes, wonderful. So everybody's right on the ball there. Do a more comprehensive physical exam, and then let's get some imaging to make sure we know what's going on. There's nothing like no other brain pathology that we can uncover here. Okay, so just going back a little bit to what a broad-based gait is, kind of like I already talked about, it's issues with coordination, spinal reflexes. I just saw that, Adam. Yes, great, wonderful, comprehensive exam there. I think it was Adam who had mentioned problems with coordination being, equivalent to a broad-based gait. Part of the brain involved in coordination. Adam, I think, already mentioned it, but if anybody else remembers what he said or can think of a part of the brain that's involved in coordination, you can drop it in the chat. Yes, cerebellum, great, woohoo, yes. And along with the cerebellum could be a basal ganglia issue, absolutely, yes. So really, the entire brain itself plays a role in movement and coordination. So when you want to do a motor task, when you're telling yourself, I want to pick up this glass of water and drink it, your brain tells yourself to do it. It goes to the basal ganglia. The basal ganglia sends inputs to the rest of the body, which is like the cerebellum, which is also down to your spinal cord, to all your muscles. And then your cerebellum also receives information about the muscle movements once you're doing them to like fine tune coordination issues and balance. So essentially, like all parts of the brain are involved in movement, but really for kind of basic purposes, y'all have often probably memorized cerebellum to be coordination. So great. So cerebellum. And okay, another thing with ataxia. Ataxia is a medical term to describe this problem with coordination or this uncoordinated voluntary movement. So broad-based gait would be a type of ataxia, and ataxia that's caused by cerebellar dysfunction is called cerebellar ataxia, because there's different kinds of ataxia, of course. Of course, you can have like something in your spinal cord that's causing an issue with balance and coordination. So that would be different than cerebellar ataxia, but really that's just a broad umbrella term for you guys to know. Okay, so we've kind of talked about the motor exam now. You guys did a great job with that. What is the significance of the headaches, the nausea, the vomiting, the blurry vision? Anybody have any insight in that? Also keep in mind that we already know that there's probably something going on in the brain, maybe even the cerebellum. So if we take that kind of knowledge, as well as the fact that he's having, these headaches, nausea, vomiting, blurry vision, what do we think that might be from? This is rare, but perhaps it could be an AVM type of issue. Yeah, so like, and I can't even say this right, arteriovenous malformation, which, yeah, in young people or in people with certain genetic disorders can have those, and those can burst, and those can cause brain bleeds. So certainly this could be present with that kind of these kind of symptoms as well. I'm tripping over my words tonight. Vertigo, maybe. Yeah, vertigo, because of the dizziness, right? The nausea, the blurry vision, even. Those are definitely signs of vertigo. So when we're already thinking that there's could be an issue in the brain, in the cerebellum, when we have headaches, nausea, vomiting, blurry vision, that can be an indication that we have way too much pressure in the brain. So let me show you. So yes, when taken in context of the entire presentation, these signs are concerning for increased intracranial pressure. So the brain is like a closed space, right? You have this rigid skull, you have your brain, you have all of the cerebrospinal fluid that is coating the brain and cleaning it, and the lymphatics and the vasculature. You have all of that in this, enclosed space. So anytime we have something else come into that space, whether that be blood, whether that be a brain tumor, anything else like that, that can cause expansion and an increase in pressure because you don't have anywhere to go, right? If you don't have an increase in volume, if you don't have an increase in volume, but you add more things in, then the pressure is going to increase. So essentially, those are what these symptoms are indicative of. So let's kind of take a look at the picture here, some of the pictures here, to go into more detail about increased intracranial pressure. So I don't know if you guys have learned yet about the ventricular system in the brain. So as I was saying earlier, you have cerebrospinal fluid in the brain. It kind of coats the brain, and it cleans it. It washes out like all the toxins at night, that kind of thing. And it gets reabsorbed up here. And so it's kind of like this entire system, right? And it's in these ventricles is where it's made. And then it travels around, it goes to the top of the brain, gets reabsorbed, and kind of just this continuous flow, right? And so if we have something in the brain, like a tumor, for instance, that is blocking the flow of this cerebrospinal fluid, what can happen is it can build up and you can get something called hydrocephalus. And hydrocephalus is where you have blockage of these ventricles and you have widening and enlarging of the ventricles because the CSF is not able to communicate with the rest of the spaces. It gets blocked essentially. And so that only further adds to the problem of the increased intracranial pressure. So when we think in terms of this patient and the physiology of what's going on, so you guys already told me like the motor exam and the cerebellum stuff, probably something's going on. He probably has some sort of brain pathology, right? So if we're thinking about a tumor, we have a tumor in the cerebellum, we have a tumor that's causing this increased intracranial pressure and it's blocking the CSF flow. And that's further exacerbating the issue because then the CSF cannot get reabsorbed and basically the ventricles will enlarge and the pressure will just become, super, super high. And so when that happens, that can cause, the headache, the nausea, the blurry vision, because it can get in the way of, the optic nerve and it can get in the way of the extraocular muscles moving and the signals to move those muscles. Ultimately, what can happen is when the pressure gets way too high, the brain can herniate. So if we look over here where my mouse is, you guys can, I don't know if you've learned at all about like the tentoriums of the brain and like basically the spaces that these meningeal layers divide the brain into. So the brain just kind of sits. So for example, like under here is the cerebellum, but like up here would be like the frontal lobe, right? And this would be one side, and then it would be divided by this one into the other one. So when there's way too much pressure, basically one side of the brain can herniate under one of these things. And obviously that's bad. And we can see it in this picture as well. Obviously that's bad because like you're smushing part of the brain, right? And so it's almost like you're that with the tracks that are in that area and that part of the whatever that part of the brain controls, like obviously that's going to be disrupted. So that's kind of like the end point. And if your brain herniates like down here at the brainstem, I mean that can just cause you to die immediately. So obviously increased intracranial pressure is like a big issue, which is why I've kind of like harped on about this. Okay, so let's go back to our guy. So what did we say our next best step was? Imaging. CT, wonderful. If he was in the emergency room, they would just send him right through a CT. MRI is the gold standard for, brain tumors and any CNS pathology for diagnosis. So that's why I just put MRI, but certainly a CT can show you stuff as well. You just probably would follow up with an MRI as well. Okay, so what happened? So let's look at this picture over here where this blue X is. I think you guys can see my mouse. So do you notice how big the ventricles are? That's like bigger than normal, right? So we're concerned this guy might have like hydrocephalus, right? The blockage of the CSF flow. And obviously we've got this big tumor, which is the one that's causing the blockage, right? Huge right here. I mean, it's like you can't miss that, right? Another picture here where you can see the tumor more in the middle of the cerebellum. So what happened in this case is the surgeons resected the tumor, and the pathology revealed it to be something called medulloblastoma. So medulloblastoma, it's the most common malignant brain tumor in children. The peak age is around 3 to 5. And like we said, the tumors often develop near the midline of the cerebellum. And so again, that kind of goes along with all of the symptoms that we saw in this patient. The ataxia, they can obstruct CSF outflow, and that can cause the hydrocephalus, the increased intracranial pressure, and then nausea, vomiting, blurry vision, all of that stuff. So with medulloblastomas, the treatment is often doing surgery, right, as best as you can. And then these patients often will also get chemotherapy and radiation because medulloblastoma doesn't have a very good prognosis, unfortunately. So a lot of the chemotherapy and radiotherapy will just be like salvage therapy and trying to prolong, the course of life as much as possible for these kids. Okay, so just really quickly, pathology of medulloblastoma. When we look at histologically, so have you guys heard of I'm sure you've heard of biopsies and stuff. So when we do surgeries and you get the tissue out, so for example, they pull that tumor out, they'll send it to the pathologist, and the pathologist will take little sections of it and look at it under the microscope. And that's how you get the definitive diagnosis of what it is, by looking at these cells. And so I tried to include some of that into this presentation. So for medulloblastoma specifically, it's characterized by what is called these Homer-Wright rosettes. So these are tumor cells. So you can see all of these really darker purple things, these tumor cells surrounding nerve fibers. What's pink in the middle here is a nerve fiber. It's like a cross section of it. So all of these are called Homer-Wright rosettes. And when you see those, you're like, oh, that's medulloblastoma. Okay, so before we get to the second case, I just want to give a general overview of how we classify brain tumors, because I think that they can be very overwhelming to try to understand. And so having a good general classification of them is important. So overall, brain tumors are either primary or secondary. So what does this mean? This means that primary tumors will arise within the CNS themselves. So they come from the neurons, from the glial cells, from the cells that make up the central nervous system, essentially. Secondary means that the cells started, or the tumors started outside the CNS. So maybe breast cancer or skin cancer, and it metastasized to the brain. So we've got primary and secondary. Okay, so then when we're just thinking about primary, because obviously secondary, that's elsewhere, right? That just metastasized to the brain. It didn't actually come from the brain itself. So we're just going to focus on the primary brain tumors. So with primary brain tumors, we have two big, large groups. They are either gliomas or non-gliomas. Gliomas mean that it came from cells, right? Cells of the nervous system, glial cells, astrocytes, oligodendrocytes, ependymal cells, all of those cells of the central nervous system that, myelinate neurons, that clean up debris, that serve as immune defense. So all of those cells of the central nervous system that do those particular job are called glial cells. And so if the tumor is from a glial cell, it's called a glioma. Now, if a tumor is not from a glial cell, but it's from something else in the central nervous system, for example, meningeal cells, it's called a non-glioma. Okay, and then further on, we have, astrocytes are a type of glioma, and astrocytoma, one of the most highest grade and most malignant types is a glioblastoma. So as we can see, so we'll talk about these as we go through the cases, but I think a general understanding, you should know that we've got primary brain tumors, secondary, and then primary, you can either be a glioma or a non-glioma. And so we've already talked about a medulloblastoma, which medulloblastomas are a type of glioma because they come from glial cells. Okay, finally to case 2. So 11-year-old girl brought to physician. Over the past 2 months, she's had dizziness, headache, nausea, clumsiness. So you have a concern for a neurological cause of her symptoms, and you say, let's just get an MRI. Let's get an MRI right away because I'm concerned that something is going on inside her brain. So here are the results of the MRI. So notice the location. How does the location of the pathology on the imaging that you see explain the symptoms she's having? Give you a minute to kind of think about it. Well, how about first, does everybody see where the pathology is in this slide? Or what's not normal? Yes, Ainsley, wonderful. Great, yep, exactly. So over here, like this is obviously the tumor, the pathology that's going on. And as Ainsley said, yes, proximity to the cerebellum, right? Because the cerebellum is in this area. That, as we learned from the first case, can cause some of the clumsiness and the issues that she's having, even dizziness with like balance and coordination. What is the next best step in this patient? We've done imaging. What do we want to do? Is that dark spot of fluid buildup, or is that part of the tumor? Lovely, love that question. That's great. That's actually fluid. Yeah, that's actually fluid in that space. And we'll talk about what that is specifically, Ainsley. But yeah, the part that's like lighting up essentially looks more white. That's the tumor. Yeah, so people are saying biopsy and send a sample to pathology. So yes, the way that we can do this, so with brain tumors, we can either go in and just do a biopsy and then send it to pathology, because if you have like widespread disease, you might not necessarily want to, there might not be an intent to do surgery and like resect anything because of where the tumor is located. Like if it's next to like very important structures of the brain and you just can't do a surgery around there, like then you might just biopsy it to get a definitive diagnosis. But in this case, the tumor is pretty well circumscribed and we can probably just do the surgery. And when we do the surgery, we'll then obviously biopsy, take the tissue and look at it under the slide. So you guys are totally right. So okay, yeah. Note the cystic structure with surrounding enhancing nodules. So I think it was Ainsley that pointed out, like, what is this dark stuff, right? So in this specific brain tumor, we've got this, the actual tumor itself, and then around it, we've got this like cyst, right? That's filled with fluid. So this is very characteristic of a specific brain tumor in children. So yes, so when we did the pathology, it comes back as pilocytic astrocytoma. So pilocytic astrocytoma, this is the common imaging that you will see, is the cystic structure surrounding this, nodule and this brain tumor. Okay, so reviewing what a pilocytic astrocytoma is. So it's the most common primary brain tumor of childhood that's benign. Like medulloblastoma that we learned in the first case is the most common malignant brain tumor of children. Pilocytic astrocytoma is the most common benign tumor. So presentation depends on the location of the tumor, but most often they are in the cerebellum. They can also be higher up in the brain or supratentorial, but that's less often. The growth pattern is highly localized. What this means is that the tumor itself is very well circumscribed. It's not like infiltrating into different parts of the brain, which is good because this means surgery is often curative for them. And patients have a high rate of long-term survival. So if you are, you have pilocytic astrocytoma, you have a much better prognosis than if you had something like medulloblastoma. And so just looking at what they would see on the pathology slide, kind of like we saw Homer Wright rosettes with medulloblastoma, pilocytic astrocytoma also has a common histological finding, and these are called Rosenthal fibers. They're these like long, and I'm sorry, you guys probably haven't done like pathology before, but eosinophilic means like this pinkish color. So these Rosenthal fibers are these long, like pinkish color type things, and they look like little hairs, which is why it's named pilocytic astrocytoma, because pyloid means hair-like. And again, here you can also see them kind of more bunched together. This is like a zoomed out version of that. Okay, so we talked about medulloblastoma, and then we've also talked about pilocytic astrocytoma. And I wonder if I can, no, okay. Okay, so that's kind of where we're at on here. So both of these were gliomas because they're derived from glial cells. Pilocytic specifically is derived from astrocytes. Medulloblastoma is as well. Okay, case 3. So we have a 61-year-old male. He's brought to the emergency department by emergency medical services after having a seizure at home, and he lost consciousness. So on exam, he appears groggy, but he's able to give a good history. So he says, over the past 3 months, doctor, I've had some recurrent headaches, I've had some nausea, some vomiting, and I've actually lost 15 pounds unintentionally. Okay. So what else do you guys want to ask the patient? So obviously, again, this is like a brain tumor lecture, so we know that's probably what's going on here. But what general things would you want to ask a patient who had a seizure? Description of headaches. Yes. History of seizure disorder. Wonderful. Was this the first time? Have you had this before? Yeah, absolutely. Those are all good history questions. What else? Thinking about like causes of seizures or anything that might have led this guy to have a seizure. What, thinking about that, what would we want to ask him maybe? What was he doing right before? Exactly. Maybe something that he was doing precipitated the seizure, right? Yes, yes. Does he have any infections? Yeah, great, wonderful. So yeah, so this was just kind of a, meningitis, for instance, great. So yeah, these are just like, I just wanted to kind of go over in general, good history, asking questions, because even though we know, oh, this is going to be a brain tumor because I'm giving a brain tumor lecture, when a patient has a seizure, you want to be thinking, okay, well, what are some of the things that can cause a seizure? And let me make sure that I ask those questions to kind of get at the etiology, get at what could have been causing this. So for example, somebody had mentioned, does he have a history of seizures? Because that's certainly a cause of seizures, like he has an epilepsy syndrome. What was he doing beforehand? Was he drinking a lot of alcohol? Did he take some prescription drugs? Was he just going a really long time without sleeping? Was he doing a lot of excessive, physical activities? So all of those are good things to ask the patient. Interestingly, brain tumors are actually one of the most rare causes of seizures. That's why it's really important to get a thorough history, because with somebody coming in with a seizure, you probably are going to get brain imaging anyway. But usually your first thing to think about might not be brain tumor. You might be thinking of all of these other stuff that I was saying that are more common than a brain tumor causing a seizure. Okay. Oops. All right. So he doesn't have a history of seizures, but he does have a history of high blood pressure, high cholesterol, and coronary artery disease. So you're concerned about the possibility of a stroke. So what imaging do you order quickly? Concerned about a stroke because of his high blood pressure, cholesterol, coronary artery disease, and the fact that he's coming in with a seizure. So if you're concerned about a stroke and a brain bleed, what do we want to get? Head CT. Exactly. Anytime you're concerned about bleeding within the brain, like a hemorrhagic stroke, we want to get a non-contrast head CT, because that will show whether or not there's active bleeding in the brain right now. So we do a CT scan, comes back this. So we're like, okay, he doesn't have a brain bleed, but something's going on there. Okay, so again, negative for acute hemorrhagic bleed, but there's a large, irregularly shaped, inhomogeneous mass in the right frontal lobe. That's causing a mass effect on the right lateral ventricle and a leftward shift of the midline. That was a lot of words. So let's go over that again. Can you guys see? So first of all, you can see this mass, I'm pretty sure. And you can see how it's inhomogeneous. So our pilocytic astrocytoma in the previous case was very well circumscribed. It made it very, a good candidate for surgery. This one's kind of just like fuzzy borders. It's kind of irregularly shaped. It also is pushing on this ventricle. Do you guys see that? And like the brain has kind of, the brain matter is kind of moved to the side, right? It's kind of pushing it to the side. So that's caused like a mass effect on the right lateral ventricle. And so it's shifted the midline there. And then this is just a different, I don't know the different MRI types. I'd have to review those, but this is just the same MRI. It's just in a different, imaging view, like T1 versus T2, those sort of things. But anyway, you can still see how this is like inhomogeneous, like I said, and it's pushing on the ventricles there. So what is the management of the patient? Do we want to surgically intervene? What do you guys think? Anybody want to do surgery for this patient? Surgical intervention is risky, and Julie, because of the non-clean border, surgery might not be the best choice. I believe somebody else had said something too. No, probably chemoradiation. Yes, great. So this was like a trick question because, yeah, I wanted you guys to say like, no, we don't want to do surgery because of the exact thing I just taught you about, pilocytic astrocytoma and the well circumscribes makes it really good candidate for surgery, whereas this one's kind of weird borders, fuzzy borders, probably won't be that good for surgery. So you guys were in the right direction, definitely thinking about the right thing. In this case, specifically, they actually did do surgery. So even though some of these masses even though it is risky, and some of these masses are not well circumscribed, with surgery, sometimes they will go in and just try to take as much as they can, right? So maybe part of the tumor is pushing on like a vital brain structure, and so they don't even want to go there. They'll still go in and get some of it, right? And part of that is that they can then obviously biopsy that and look at it under the microscope. But you guys were thinking of, all of the right things there. Okay, so this, so based on the clinical picture and imaging, you are nearly certain that this is an aggressive form of brain cancer called a glioblastoma. So you plan for surgery with the intent to remove as much as possible. But due to the infiltrative nature, some of the tumor will be left. So the patient will get chemo and radiation, as someone had mentioned. So pathology from the surgery returns, and we've got this. So this biopsy is indicative of glioblastoma. So we had homocyte rosettes for medulloblastoma. We had the Rosenthal fibers for pilocytic astrocytoma, and both of those were childhood brain tumors. The hallmark for glioblastoma are these pseudopaliciding necrosis, these areas of pseudopaliciding necrosis. It's like a just fancy term. Essentially what it means is these hypercellular zones. So you can see all of these cells, all these little purple things, those are all cells, these hypercellular zones around the central area of necrotic cells. This is necrotic debris, meaning that cell death is occurring here. That's why you get this like pink area, and you can't really see where the cells are because the cells have died. So you have a bunch of cells surrounding this necrotic area, and that is that's a hallmark of glioblastoma on pathology. Okay, so let's talk about glioblastoma because it is, like I said, one of the most, or it's the most high-grade malignant brain tumor that there is. So it's the most common type of diffuse astrocytoma. So it is a type of astrocytoma. So again, it falls under that category of glial tumors or gliomas. And it can cross, something interesting is it can actually cross the corpus callosum to the other side of the brain. So if we look at this one, our guy didn't have this, but in some cases it does do this. And so it's termed like the butterfly imaging that they see on scans. So you can see how this tumor has spread and it's crossed the corpus callosum, or, you know, the white matter tract that connects both sides of the brain, and it's infiltrated onto this side as well. And so you can see that in this picture also. You can also have like bleeding within the tumor, which is obviously not good. And that's from like the tumor itself is very, it makes a lot of new blood vessels. Cancer cells and tumors love to make new blood vessels because that's how they get, you know, nutrients and oxygen, and that's how they help themselves continue to grow. But some of those blood vessels can break and lead to hemorrhage within the tumor itself. Symptoms, again, for glioblastoma are going to be those that are common for all types of brain tumors, right? Because it all goes back to that like increased intracranial pressure. Regardless of what tumor you have, if you have a tumor in your brain, you're going to have an increased pressure in some of these symptoms because, again, the brain is an enclosed area and an enclosed space. And glioblastoma is a very poor prognosis. So the median survival is 15 months. So when you think about a very malignant brain tumor in adults, think of a glioblastoma. And you guys have probably heard about this before. I mean, maybe you have, maybe you haven't, but it's definitely one to know, which is why I picked it as one of the brain tumors to go through. Okay, so what have we talked about so far? So we've talked about medulloblastoma, again, childhood brain tumor. It's the most common malignant brain tumor of childhood. We've talked about pilocytic, which is the most common benign, and it's very much treatable for children. And then now we've talked about glioblastoma, which does not have a good prognosis, and it's common in adults, and it's very malignant. The president's son died from glioblastoma. Yeah. Okay. Okay, so let's do the last case here to wrap it up. So we have a 50-year-old woman coming to the primary care physician. She's got a 2-year history of increasing weakness in her extremities and neck pain. She first noticed weakness of her right upper extremity 2 years ago, which has progressed to her right lower extremity, and now she also has involvement of her left side as well. Examination shows an ataxic gait, and she's got dysarthric speech. That means she's just having difficulty speaking and making words, kind of like I am tonight because I'm talking so fast. I apologize, I should slow down, but I stumble over my words when I talk fast. But essentially that's what, you know, she's having difficulty articulating things as well. There's atrophy of the sternocleidomastoid muscle and trapezius muscles. And then the deep tendon reflexes are increased bilaterally. So this lady's got a lot going on her exam, right? It's a very robust neuro exam. So with these symptoms, and I don't expect you guys to know this, but you know, you can kind of give it a go because I know we talked about like tracks and localization previously. So if you remember anything, we can give it a go and think about where the localization of her problem could be. Motor cortex issue, lovely, great. And kind of near Broca's area. So Adam, why are we thinking, one, why are we thinking motor cortex? And two, why are we thinking Broca's area? Speech issues, great, yeah. So for those of you who are not familiar, there are like areas in the brain one's called Broca's area, which is more anterior, and it's more towards the frontal lobe along one of the fissures of the brain, and that's involved in like the motor component of speech. So being able to speak coherently. And then there's another part of the brain that's a little more posterior along the fissure and like towards like the parietal occipital lobe called Wernicke's area. And that's issues with like comprehension, kind of like Adam was saying, is she can still comprehend, but she's having issues with speech, like the motor type of speech. So that could be near Broca's area. And again, probably the motor cortex issues, right? Because we also are having these upper extremity, lower extremity weakness. Okay. Okay, so, all right, so I had said the increased reflexes indicate this is an issue with the cerebral cortex. The dysarthria and atrophic SCM, oh, I didn't talk about that yet. The atrophy of the sternocleidomastoid is concerning for a cranial nerve involvement. So yes, very much so, the dysarthria could be involvement of basal ganglia, it could be involvement of Broca's area, any part of the motor cortex. You know, there's lots of possibilities. But taken in the context of the fact that she also has this like atrophic SCM muscle and atrophic trapezius, we're kind of trying to think about, well, where are the fibers that go to both of those muscles? And how does that also fit in with dysarthria? And how does it also fit in with this weakness that she's having? And so that kind of leads us to think, oh, the brainstem, because the brainstem near that area is where we have the cranial nerves that are leaving to go to the SCM and the trapezius. It's also where we have the motor tracts going down into the spinal cord. And it also has the cranial nerves that can help with speech, you know, tongue movement, things like that. So what is the next best step for this patient? You have a patient that just has all of these neuro problems. What do we want to do? Do we want to just start operating on her? Cranial nerve test and imaging. Yes, sure. That's wonderful. Yeah, let's do a little bit more comprehensive test. Let's also do some imaging. So yeah, imaging, MRI is the gold standard. Okay, so this is what you get. Okay, so note how the areas of hyperintensity, so which is the white signal right here, note what that is. Obviously, that's not normal. So also note how the tumor appears round and well-defined. So not like the glioblastoma, but more like our pilocytic astrocytoma picture. So can anyone name where in the skull this tumor might be located at? Woohoo, foramen magnum. Yeah, great guys. That's awesome. So yeah, let's just do a little review of the foramen magnum. So this is kind of the skull. Hopefully you can see it's kind of just like flipped, right? It's flipped so that you can see like the bottom of the chin here. And you can see this foramen magnum, which is just essentially like this hole in the skull through which the spinal cord travels through. So like the cerebellum sitting right here, the brain stem's coming through here, and the spinal cord is leaving the part of the brain stem to go to, you know, the lower part of the body through this foramen magnum. So if there's a pathology here, which obviously there is, because we see this big, you know, big tumor sitting right there, this explains the dysarthria and the atrophy of the SCM and the trapezius, because the cranial nerves that control those muscles are near that area. Additionally, all of the weakness symptoms is certainly explained by where this is, because the motor tracts that we learned about pass through this area in the spinal cord. And so if we disrupt the motor tracts, then we start to have some of those symptoms that we had talked about earlier, the weakness and all that kind of stuff. Okay. So this patient has a meningioma. I wanted to include meningioma because it is a very common benign brain tumor in adults. And a meningioma is not a glioma like the other tumors we've talked about. It's actually made of cells that are not glial cells. It's made of cells called arachnoid cells. These cells in the brain are those that help, you know, facilitate CSF resorption. Like I talked about, the cerebrospinal fluid needs to continually be reabsorbed so that you don't have any blockage, so you don't have increased intracranial pressure, that sort of thing. So On imaging, it's well defined. And what this means, again, as we've been taught, is that surgery is often curative. You don't usually need anything like radiation or chemotherapy. And the interesting thing about this tumor is that it's often asymptomatic for a long time. So if we think back to our presentation of this patient, she had this 2-year history, right? So that was different than, the little boy that had like, 3 weeks or something like that. So it's often like really, really slow growing. And so many times we just like watch and wait. We don't even intervene on it, because if it's not impinging on like any other like brain structures and causing symptoms, then it can just chill, right? Because brain surgery is obviously very risky. But in this lady, in her case, the meningioma was growing and impinging on those cranial nerves that were leading to, the muscles, impinging on the spinal cord, which was affecting her motor skills. And so obviously surgery would be indicated in her case. So also noting the pathology, like we've talked about with the other brain tumors. This one's interesting because it has what's called psammoma bodies, which are intracellular calcium collections. These things right here, that's a psammoma body. It's also got this onion peel arrangement. So those are two like hallmark buzzwords for meningiomas. Okay, so we've talked about those, and we've talked about now one of the non-gliomas that you should know about, which is the meningioma. Okay, those are my sources. We've got the quiz that you guys should have access to, but does anybody have any questions or comments? Anything you want to talk about? Any questions? Okay. Are you planning on going into neurology? I am not. I love neurology. I thought about it, but I'm doing internal medicine because I couldn't pick I couldn't pick a single thing. So internal medicine kind of gives me the opportunity to, learn everything, take care of any kind of problem. So that's why I'm doing internal medicine. But certainly there's a lot of neurological problems that we see on the inpatient internal medicine floor. So, but yeah, neurology stuff is just very fun and fascinating, I think. So, but thanks. Are brain tumors or metastases more common in adults? Yeah, maybe I skimmed over that part. Sorry about that. So yes, primary brain tumors and secondary brain tumors. Secondary brain tumors, the metastases are more common, right? So primary tumors are the tumors that arise within the CNS cells themselves. So like we talked about, gliomas and everything like that. Those are actually a lot less common than the metastases. So a lot of times when you have somebody, with a brain tumor, a brain cancer, it's from, skin cancer that's metastasized to the brain, or breast cancer that's metastasized to the brain. Those are more common to see.